Good evening, everyone. Thanks for being here. It is my privilege to introduce today's speaker, Dr. Anand Hinduja, who is a highly skilled physician with over 15 years of experience. He possesses expertise in various medical domains, not only in diabetes, but thyroid, osteoporosis, obesity, and other lifestyle disorders. He holds an MBBS and MRCP from UK in endocrinology and diabetes, along with numerous certifications including SCOP certified physician for treatment of obesity, and he has also a certificate course in CKD. Dr. Hinduja is committed to exemplary patient care, utilizing the latest technology and comprehensive approaches to ensure optimal outcomes. With a strong focus on education, he has been a frequent faculty member at Symbiosis International University, actively involved in clinical simulation for 9 years. Dr. Hinduja's extensive research and publications reflect his dedication to advanced medical knowledge and improving patient care. Additionally, he has a rich background in healthcare consulting, contributing significantly to hospital planning and management projects. Dr. Hinduja's academic achievements and awards underscore his commitment to excellence in the medical field. Dr. Hinduja will be talking about diabetes and chronic kidney disease, which we call CKD in short. Over to you, Dr. Anand Hinduja.
Thank you so much for the kind introduction, Dr. Shariq. Good evening, everyone. And today we're going to talk about a very, very unhealthy combination of disease, diabetes and chronic kidney disease. Unfortunately, the combination has been underestimated. And now we have millions of Indians suffering from chronic kidney disease and diabetes being the most common cause of this CKD. Now, whenever a patient comes to us in practice and is primarily identified as a diabetes patient, we always, for many decades, followed a glucocentric approach. The whole idea of the consultation was to get the sugars down. And we utilized the drugs at our hands and ensured that the patient's fasting and postprandial sugars come down. Hopefully, the HbA1c levels come down, and we are in safe zone. But over the last 2 decades, we've realized that this is not sufficient, and just following a glucocentric approach will not be favorable for the patient's long-term care. And we are not taking care of the end organ damage that is persistently happening in diabetes. And one of the key organs that gets affected in diabetes is the kidney. And that is why in our routine practice now, we have to identify chronic kidney disease, try to trap it at very early stages where it is reversible, and ensure that the patient has a good quality of life. So let's get started and understand how these two are linked to each other and what is the actual problem that we are facing right now. When you look at the prevalence of diabetes, I mean, this is still the tip of the iceberg. We're talking about 9.6% diabetes among adults aged 20 and above. I feel the data is definitely very insufficient. A lot of Indians have hidden diabetes. They're not even diagnosed, screened in routine screening practices. And that is why this number is definitely not the exact number that we are facing at the moment. So we are second highest in the world. Soon we'll be the highest, and that is nothing to be proud about. 1 in 11 adults is living with diabetes. Another 1 in 5 is living with pre-diabetes. Over 53% of the adults living are undiagnosed, as I told you. So these numbers are humongous. They're staggering numbers in front of us. And in a few years, we'll have 1 in 5 would be diabetic in a few decades from now. And that will really be a very troublesome and problematic future that we envisage. And that is why we need to take steps now, not only to reduce the burden of diabetes, but to reduce the burden of various chronic complications that occur with diabetes, both microvascular and macrovascular. Now, when you look at the whole spectrum of chronic kidney disease, you will realize that nearly 1 in 2 chronic kidney disease patients is actually a diabetic. And that is why controlling the sugar levels is key in avoiding the worsening of the kidney function. Okay. Another set of patients, nearly 1/3 of them have high blood pressure. And sometimes, obviously, and not sometimes, in fact, many times, we have patients who have both diabetes and hypertension. So a patient coming to you with both diabetes and hypertension, that's a red flag. You need to monitor the kidney function very regularly, because this patient has nearly 65% chance of developing a CKD. The actual organic kidney disease is prevalent in rest of them. We will not be focusing on that right now. But what exactly happens in hyperglycemia? There is a microvascular dysfunction occurring in hyperglycemia at the level of the glomerulus. There is a difference in the functioning of the kidney, leading to increased release of albumin from the kidney, and that is in the form of albuminuria. Initially, it's microscopic, and later it's microalbuminuria or proteinuria, and increased extracellular volume and blood pressure, progressively leading to end stage kidney disease. Okay, so there are a lot of factors working, and here one key factor which really changed the dynamics in the last decade or so was the SGLT2 expression. Okay, and is this SGLT2 sodium glucose co-transporter 2 expression that has really revolutionized the treatment of diabetes, and along with it revolutionized treatment of heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and chronic kidney disease all in all. Moving on. So when you look at CKD, it's a progressive, irreversible loss of kidney function. But as I said, in early stages, definitely it is reversible. We can reverse the creatinine levels, we can reverse the EGFR, and the patient's quality of life can be prolonged. And there are all these factors occurring. There is a level of kidney damage occurring at the physical level. There are certain pathological abnormalities occurring at the level of the glomerulus and the nephron. The glomerular filtration rate definitely is an indicator of where we are headed. And a value of less than 60 ml per minute continuously for 3 months of longer in the absence of any other possible cause like an active infection or renal calculi. In such cases, definitely we are talking about chronic kidney disease. Looking at the classification and screening of CKD, again, this has changed dramatically in the past decade or so. And now when you look at the CKD classification, we are seeing a very colored chart in front of us. What does this tell us? It tells us that the initial understanding was to over-focus on the creatinine level and therefore the glomerular filtration rate. But what we were ignoring for many years is the role of albuminuria in chronic kidney disease. And now that we've integrated both, we have a kind of a matrix in front of us which tells us that how CKD is understood better when we take both the values into consideration. So what you need to do is, whenever you have newly diagnosed diabetic patient, check the creatinine level and therefore the EGFR, and do a spot urine albumin creat ratio of your patient, and that will really benefit. When you do the spot urine ACR and EGFR, you will get the results, and this result can be entered, and then you will know whether you need to really just screen the patient regularly, or you have to start treatment. If you need to treat and refer the patient, whether this is a patient with a low risk, moderately increased risk, high risk, or very high risk. So such beautiful stratification can be achieved with two very commonly done tests, that is the spot urine ACR and the EGFR. Okay, so when you look at the screen now and you focus on the numbers here, we are talking about a patient who is actually safe zone is a one who does not have microalbuminuria and has an EGFR of about 60. So any patient having EGFR of about 60 with a microalbuminuria score of less than 30 is one who's in safe zone, and thus needs only regular screening. Possibly annual screening should be sufficient. Okay, and then you look at the other cases where there is microalbuminuria, and although the GFR is maintained, these patients need to be treated. So this I will not I think there's nothing enough that can be underscoring this or emphasizing this, that you need to treat patients who present to you with microalbuminuria, that is a ACR range of 30 to 300, even with a normal GFR. So they are still chronic kidney disease, and they fall in that category of A2G1 or A2G2. Okay. Thirdly, if the EGFR has fallen to 45 to 59 in the absence of albuminuria, even these patients need to be treated. So this is your first zone of moderately increased risk. Okay. And then further on, you have a high risk, the very high risk, and so on. So a type 1 diabetic patient should be screened at 5 years after diagnosis, initial diagnosis, while a type 2 diabetic, as I said, at the first diagnosis itself or first consultation itself, ensure that you check for spot urine ACR and EGFR, and then further screen the patient. Okay, so evaluate positive temporary or spurious causes. Look at cystatin C in case you feel that creatinine is not the right test to do, and it would not precisely estimate the GFR. Cystatin C is a very robust test, although a little costly, but once it can be done to assess whether the chronic kidney disease is in fact true. And you need to then start evidence-based treatments, which we will focus on in the coming slides. Moving on, when you look at the therapeutic strategies, as I told you, we need to shift from the glucose-centric approach, utilize newer drugs which have very good mechanisms, pleiotropic benefits being offered, and that is why robust early combination therapy should be instituted in order to prevent microvascular damage and in order to prevent a negative metabolic legacy effect. Please remember, the first 5 years of diagnosis of diabetes are the most crucial, and it is in these years uh, that we don't really pay attention to the diabetes control. And what happens is that when you don't do that, the microvascular and macrovascular damage continues. Now, what happens after 10 to 15 years is that the patient is now well controlled, okay? But he has developed chronic kidney disease, he's developed retinopathy, he's developed neuropathy. So, what to do in such cases? In such cases, the blame lies on the initial poor treatment provided to the patient, whether the patient was not serious or the doctor was not serious or there was inertia on that front, but that needs to be corrected, okay? So you look at novel medication therapy, you look at DPP4 inhibitors like sitagliptin, linagliptin, saxagliptin, vildagliptin, all these are used commonly in our practice. Okay. So what does the DPP4 inhibitor do? Basically, it inhibits the GLP-1 and GIP. It stimulates the insulin secretion from the beta cells. So it has a certain insulinogenic effect. It inhibits glucagon secretion from the alpha cells. It's weight neutral and extremely low risk for hypoglycemia. Very safe drugs to give even in elderly. And then SGLT2 inhibitors, very new. I shouldn't say new, we have been using it for more than 10 years, but relatively new compared to other classes. And what do these drugs do? They inhibit the renal glucose absorption. They work on the SGLT2 expression. They promote weight loss. They reduce the systolic and diastolic blood pressure. Again, low risk of hypoglycemia. The GLP-1 receptor agonist, wonderful drugs to be used in practice. The only limitation being the gastritis being caused in certain cases. And in certain cases, we obviously the affordability becomes an issue. Everybody is not willing to invest in GLP-1 receptor agonists for a long period of time. So within these three drugs, if you have to choose a fixed dose combination, a good combination could be an SGLT2 inhibitor coupled with a DPP4 inhibitor. Okay, so that would be a suitable option for Indian patients for various reasons. One, obviously, you're getting safe, rapid, sustained glycemic control. It's improving both insulin resistance and beta cell function. It helps reduce body weight and blood pressure. Okay. It reduces the pill burden, that is adherence and compliance improves, and it is overall cost effective in approach. So I think this is a very good combination, extremely safe to be given across age groups and giving a vast number of pleiotropic benefits apart from sugar control. And we'll know that, especially in relation to kidney, how this combination is beneficial in the coming slides. So when you look at SGLT2 inhibitor and DPP4 inhibitor primarily in diabetes management, we're looking at dapagliflozin in combination with sitagliptin, which is very well tolerated, leads to clinically meaningful reductions in glycemic parameters and body weight, which are sustained through 48 weeks of treatment. Okay, so over a long period of time, the benefits are sustained in such cases. So it's very durable and gives you long-term efficacy without causing side effects in most patients. Okay. Now, when you look at the SGLT2 action and how it is giving us a synergistic benefit when coupled with DP4 inhibitors, you can see that SGLT2 inhibitors are primarily insulin-independent glucose-lowering drugs. So they can be used at any stage in the life cycle of diabetes and in the natural history. They are not drugs which will be effective in the initial phases and not useful later on, like most sulfonylureas. And what do? They reduce the glucotoxicity. They increase the glucose excretion via urine. Okay, they improve the beta cell sensitivity, decrease insulin resistance. They also increase the endogenous glucose production. And now what happens is DP4 inhibitors counteracts this particular problem that SGLT2 inhibitors could cause. And what they do is they reduce the endogenous glucose and glucagons. They also reduce the vascular oxidative stress, especially in the kidneys. They improve the endothelial function, the insulin secretion, and incretin effect which is the primary action of DPP-4 inhibitors. So multiple organs being acted upon, its gut, pancreas, kidney. They're weight neutral. SGLT2 inhibitors cause weight loss. So overall, when you use a combination, you will get definitely weight loss. Synergistic effects. So you get improvement in the glycemic control, improvement in albuminuria, serum uric acid, systolic blood pressure, across the board cardiovascular risk reduction, and the chronic kidney disease risk reduction. So all in all, wonderful combination of drugs. I think we are all using these combinations, but it's always good to recapitulate the information available, and that then we are sure that what we are doing is evidence-based practice. Moving on. So look at benefits of SGLT2 per se, and how they are really working. They work on the liver, increase the non-esterified fatty acid utilization, increase hepatic glucose output, decrease ketogenesis, decrease steatosis. So they are definitely useful even in fatty liver disease. A lot of studies are now ongoing on the utilization of SGLT2 inhibitors in fatty liver disease. And in years to come, we will now have SGLT2 inhibitors as a primary liver drugs. If I would like to tell you some latest information, the KDIGO 2024 guidelines just released have now classified SGLT2 inhibitors as a first-line drugs in chronic kidney disease, independent of the glycemic status of the patient. So now you can use SGLT2 inhibitors as primary drugs in chronic kidney disease, independent of the patient's diabetic status. So even if the patient is non-diabetic with kidney disease, SGLT2 inhibitors are the first line of drugs. The same when you look at heart failure with preserved ejection fraction, according to all international guidelines now, the first primary drug to be initiated in a patient with HFpEF or heart failure with preserved ejection fraction is SGLT2 inhibitors. Across all ejection fractions, the safest drug to be given and one of the key pillars in heart failure with reduced ejection fraction, with moderately reduced and preserved ejection fraction is SGLT2 inhibitors. Okay. So across the board, very useful drugs now in kidney disease, in heart disease. Soon with the trials being completed for liver, you will get the data that it's very useful even in liver disease. Okay, so it has excellent action even in the heart. You will see reduced arterial stiffness. It reduces a vascular volume, and that is why the chances of dehydration is very less. Okay, it's intravascular where it acts. Improved endothelial function, reduced chance of congestive heart failure, increase lipolysis, decrease fat mass, so it acts very well on visceral fat and reduces its quantity. Decrease oxidative stress, decrease fibrosis, increase diuresis, increase uricosuriya, even the uric acid levels reduce in the patient. So all in all, I think except for a couple of things that we need to be careful while using SGLT2 inhibitors, especially that is the maintaining the intravascular volume. Patient needs to drink a good amount of water, and the taking care of genital hygiene and urinary tract hygiene. I think these are the key things. Once the patient starts following that, the chances of side effects are minimal, and you can get a host of benefits from SGLT2 inhibitors. Okay. So looking at the DAPA CKD guide, the trial, and what did it say? That the composite of decline in eGFR was at least 50%. Okay, and you know, in terms of end-stage kidney disease or death from renal or CV causes, declared to me landmark trial, telling us that the composite of more than 40% decrease in eGFR to less than 60 ml per minute per 1.73 meters square, end-stage kidney disease and death. And again, DAPA HF also giving us similar data in favor of the drug dapagliflozin compared to placebo. So evidence-based studies have shown that dose adjustment in CKD is not required up to a level of 25 ml per minute. The KDIGO guidelines now have extended this to up to 20 ml per minute in the latest data. And we look at sitagliptin, we know that sitagliptin will need some titration, and then you have to go up to 50 mg and then 25 mg of sitagliptin that can be used in CKD. Okay, so glucose lowering efficacy is reduced with SGLT2 as the eGFR decline. So you may not get that kind of benefit in terms of glucose lowering, but you'll definitely get a lot of benefit in terms of kidney and cardiovascular benefits. Okay, so dapagliflozin is approved for use at 10 mg once daily. As I told you, now the latest KDIGO guidelines have reduced the number till 20. So looking at the holistic approach for patients with diabetes and CKD, you need to do regular risk factor assessment every 3 to 6 months. Focus on healthy diet, physical activity, smoking cessation, weight management. All these are very essential. Don't completely depend on drugs unless and until the patient does not follow a healthy diabetic and renal diet. does not indulge in moderate physical activity, continues smoking, or keeps putting on weight, you will not get the desired result in terms of improvement in the diabetes or the kidney disease levels. Okay, so SGLT2 inhibitors are the first line drug therapy. Initiate if the EGFR is more than 20, okay, and then you can continue until dialysis or transplant. So important is initiation at a higher GFR. Metformin if the EGFR is more than 30, otherwise in lower EGFR levels, it could increase the risk of lactic acidosis, and that's why it's not utilized. RAS inhibition at maximum tolerated dose. Again, if there is hypertension, okay, so you have to also use moderate or high intensity statins. Cholesterol levels need to be under control. And then additional risk-based therapy, you could add a GLP-1 receptor agonist or a non-steroidal MRA in terms of renal function. But again, you have to look at the ACR levels, you have to look at the potassium levels, you have to look at the creat levels. All these things need to be taken into consideration. CCBs or diuretics can be used to achieve the individualized targets, or steroidal mineral receptor antagonist in cases of resistant hypertension. Antiplatelet agents for clinical atherosclerotic cardiovascular disease. Remember, in ASCVD, the kidney risk goes up. And other drugs like ezetimibe or PCSK9 inhibitors in case you're not achieving the target LDL cholesterol levels. And that could be additional risk for heart disease amongst your kidney disease patients. So all in all, it's a very, very large spectrum of drugs. SGLT2 inhibitors are the main pillars. Metformin in certain cases, GLP-1 receptor agonist, as I told you. RAS inhibition, very crucial. Additionally, non-steroidal MRAs like Kerendia can be used. Moderate or high-intensity statins, antiplatelet agents, all in all, need to be prescribed along with definitive lifestyle changes to be utilized by the patient. So this is all from my end, and I wanted to keep it short and sweet in terms of the presentation, not just going too much into the theory part, but we have covered larger aspects of the approach in case of patients with diabetes and CKD. From my own clinical practice point of view also, it is very important for you to understand that screening is the key. Unless and until you don't screen your patients with CKD, you won't even diagnose it. So treating it is a very far-fetched thing, right? So you need to screen your patients regularly. And once you are sure that the patient falls in the category of CKD, immediately start treatment. Ensure that SGLT2 inhibitors are part of your regime. As I told you, RAS inhibition, again, is very crucial in most patients. So using an ACE inhibitor or an ARB, very useful in such cases. Blood pressure control is very important. Key lifestyle changes to be incorporated: healthy diet, renal diet as we call it, physical activity, smoking cessation, and weight management. All in all matter for the patient. So this is all from my end in the presentation. I'll be happy to answer any questions that might arise from the discussion. Yes, over to you.
Fantastic talk, Dr. Hinduja. Thank you very much for making it very clear to us the connection
Thank you, sir.
between diabetes and CKD. Though you touched every aspect, but I'm sure there'll be some questions. So
Yes,
maybe with that we can send the clear cut carry home message. So let me go to the questions section. Yes, there are questions, though you touched all of them, but it would be nice if you could just give a brief reply
sure.
to each of them so that we have a good carry home message. The first question is, what are the early signs and symptoms of CKD in individuals with diabetes? This often
So,
patients ask us.
yeah, so CKD is generally a silent disease, as I told you. First, there will be obviously a underlying cause like uncontrolled diabetes or uncontrolled blood pressure. So the symptoms might be linked to those. Patients will not clearly come to us with any kind of kidney disease symptoms in the initial stages. Obviously, in later stages, when there is a proteinuria, that could be the first maybe symptom or sign that the patient could present with. In some cases, obviously, if there are other antecedent causes in diabetes, the urinary tract infections are very common, so they might present with UTI along with CKD. In such cases, we need to be careful while interpreting the EGFR levels because the infection needs to be treated completely. And then after a few weeks, we need to review the creatinine levels, the microalbuminuria levels, and then label them as CKD. But primarily, there are no such active signs and symptoms that patients will present. That is why, as I said earlier, also, and I reiterate the point that screening is the key. So we have to screen patients and identify them at risk of chronic kidney disease.
Absolutely right. We every day have to impress upon patients that don't wait for the symptoms. By the time you have
Yes.
symptoms, it's too late. The early detection is the key.
Yes.
So, second question is how can diabetes management help prevent or slow down the progression of CKD?
Could you repeat, sir? I couldn't get the question.
How can diabetes management prevent or slow down the progression of kidney disease?
Yes, so there is a lot of evidence in this regard, as I told you. And when we know the tight control of glycemia, and when we look at HbA1c levels of 6.5 to 7, especially in younger adults with diabetes with no comorbidities, we can bring them to 6.5 to 7. We realize that the advanced glycation products are reduced in the body and they don't go and deposit in the endothelium. And that is why the endothelial dysfunction is improved. Please remember there's a common soil theory here. Insulin resistance and endothelial dysfunction happen parallelly. So, a patient coming to us with cardiovascular disease or renal disease, it is very, very imperative on our end to look at the insulin function and insulin resistance in such cases. When we don't do this, what we are ending up doing is we are allowing the patient to live with that endothelial dysfunction for a longer period of time, and which initially presents as hypertension or diabetes could then progress into end stage heart failure or chronic kidney disease. That is why early control of diabetes would reduce the insulin resistance, would in turn reduce the endothelial dysfunction, and that is why slow down or even prevent the progression of chronic kidney disease.
Right. So, when it comes to screening, so what are the recommended screenings and tests for detecting CKD in individuals with diabetes? How do
So,
we
as I
screen?
said, yes. So, a type 1 diabetic patient would not require kidney disease screening and diagnosis because for the first 5 years, the patient might not have any trouble, especially because the problem there is insulin secretion rather than insulin resistance. So, in type 1 diabetics, the screening can start 5 years after diagnosis. But in type 2 diabetics, we really don't know since when they have type 2 diabetes, since when they have insulin resistance. They could have had a prolonged period of diabetes before they were even screened for diabetes itself. And that is why, in such cases, in the first consultation itself, we should do screening for kidney disease. And as I said, if it falls in the green zone where there is no evidence of chronic kidney disease, then the screening can be limited to once a year. You need to do the two tests. One is a spot urine albumin creat ratio, and the other is the creatinine, with which we calculate the EGFR based on the body, the age of the person, and the sex of the person. And these two values should then be corroborated and then decided whether the patient has any evidence of CKD or not.
So, can you explain the concept of renal hyperfiltration and its role in the early stages of diabetic kidney disease?
So this is a little paradoxical. Initially the patient's EGFR might go up and the patient might be happy that, my EGFR is really high. But if it is definitely going above 120, this is considered to be hyperfiltration. In such cases, it's indicating that there is a certain load or pressure on the kidney, and that is why it is trying to compensate by hyperfiltering. This is similar to what happens when we eat a lot of sweet things, and our insulin levels keep going up. And when we check for the insulin levels, they're very high, and we might say we have good insulin levels. Actually, it's not good, it's pathological insulin levels, because that in later days leads to fatigue of the at the cellular level, and similarly there's fatigue at the renal level, and this hyperfiltration would then trigger a cycle of apoptosis or cellular death, after which the EGFR will start sliding down drastically from down below 60. And that is why in such early case of hyperfiltration, I think that's a very good sign of picking up patients who could end up with chronic kidney disease in the coming years.
Right. So, the next question is how do inflammatory pathways contribute to the progression of both diabetes and CKD, and are there targeted therapies addressing this interplay? So,
Very
role
good
of
question.
inflammatory pathways in diabetes and kidney disease.
So yeah, so the first thing that we all have to understand, diabetes is primarily not only a defect of secretion or defect of insulin action, it is also an inflammatory disorder, and that is why it's a degenerative disorder. How much ever we try to control diabetes over the years, the levels tend to deteriorate, and then we have to keep adding drugs or insulin in some cases. That clearly shows a role of inflammation in such patients. So when we talk of drugs like SGLT2 inhibitors or DP4 inhibitors for that matter, they end up reducing oxidative stress. They are anti-inflammatory in nature. And that is why these drugs are considered to be superior compared to simple secretagogues like glimepiride, which will only end up causing improved insulin secretion from the remaining beta cells. So drugs like DPP4 inhibitors and SGLT2 inhibitors end up reducing the inflammatory markers. They reduce the inflammation occurring at the cellular level, and that is why they can halt or slow down the pathways which lead to worsening of the disease. Now, when you look at heart disease itself, now the understanding is that you should not look at only cholesterol levels. We should look at high sensitivity CRP levels. Why are we looking at HSCRP or high sensitivity CRP for that matter? Because we are now realizing that patients coming with high cholesterol coupled with high HSCRP are the ones who are at high risk of a adverse cardiac event. So that clearly shows it's not only the levels of cholesterol per se in the body, but the additional accompanying inflammation that is worsening a heart disease presentation. Similarly, in kidney disease, the deterioration occurring in certain patients, even younger patients developing kidney disease, is basically because the inflammatory markers are in play in such cases. Yes.
Right. Thank you. So you discussed this nicely, the role of SGLT2, but just for the sake of those carrying those points to home, can you explain again the specific renal benefits of SGLT2 inhibitors and how they prevent CKD in
Yes.
diabetes? That was
So
my
when you
big
look at
question.
when you look at the role of SGLT2 inhibitor, as I said, that the interesting thing was the understanding of the SGLT2 expression, which is modified in CKD patients with diabetes, and that is why whenever we institute a SGLT2 inhibitor, it has a insulin independent effect. That means in any point during the natural history of diabetes, these drugs can be added to the current standard of care, and they will give you additional benefit. The action is completely independent of the pancreas. It's directly at the level of the kidney. It inhibits the SGLT2 expression. It inhibits the glucose reabsorption, helps in removal of the glucose via the pathway of urine. This also leads to calorie loss, and that is why it contributes to weight loss, which is very useful because we know about the KG A1C paradox. Patients who keep gaining weight find themselves in a difficult dilemma of controlling their HbA1c levels in spite of good drug usage. That is why weight loss is very crucial. Obesity itself is an additional burden, and that is why SGLT2 inhibitors give very good, modest to good weight loss in most patients in our practice, especially in those whose SGLT2 expression is more deteriorated. In such cases, we get much better results. So there is renal glucose reabsorption, there is reduced oxidative stress, the protection of the glomeruli, protection of the nephron function. All in all, in the long run, it will reduce the chances of ending up in end stage kidney disease or dying of from any renal or cardiovascular causes.
Thank you. So you would recommend SGLT2 inhibitors to all, or are there any specific patient populations that may benefit more from the combination therapy of SGLT2 inhibitors and DPP4 inhibitors in terms of CKD prevention? Using
So in
both,
terms of so in terms of Asian patients, if you look at the data also, whether it's insulin resistance, is it insulin secretion, whether it is SGLT2 problems with SGLT2 expression, or you look at the incretin defect, all of these four are accentuated in Asian patients compared to their Caucasian counterparts. And that is why if we follow the ESC guidelines or the ADA guidelines or even the Indian guidelines, now we have started classifying patients at diagnosis into two categories. One, without any antecedent complication, the other having either ASCVD, HF, or CKD, one of the three. If the patient has any risk of ASCVD, HF, or CKD, the first line of drug is now an SGLT2 inhibitor or a GLP-1 receptor agonist, not even metformin. So in such cases, in an Indian patient who has limited affordability, SGLT2 inhibitors become the first line because GLP-1 receptor agonist cannot be used across the board. So that is why I would personally prefer that if you follow evidence-based practice also, initially risk stratify the patient, and you will find majority patients falling either in ASCVD, HF, or CKD risk. And the drug should be a part of your prescription. You should institute SGLT2 inhibitors in such cases for long-term legacy benefits and prevention of end organ damage.
thank you. So let us move on to biomarkers. So are there any specific biomarkers or indicators that can help clinicians predict the effectiveness of combination therapy in preventing CKD in diabetes patients? Any
So I think
biomarkers?
as I mentioned earlier, cystatin C is a very good test and it's underutilized because it's not available so frequently in all laboratories. But now I think even that usage is increased, especially in cities. Uh, so what happens is that patient who have muscle mass, either very heavy muscle mass or very low muscle mass, the creatinine at times can be a misnomer in such cases, and we could either overestimate or underestimate the EGFR levels. And in such cases, cystatin C is a very, very neutral marker. It's independent of the muscle mass, and it can give us a good prediction of whether the patient is in early CKD or in late CKD. And that is why once a year or once in 6 months in such patients, we can do the cystatin C test to see whether the SGLT2 inhibitors or DP4 inhibitors that we're using, whether they're really improving the kidney function or not.
Right. Thank you. Uh, I think this question should have been the first question anyway. So, what role do lifestyle modifications such as the diet and exercise play in conjugation, conjunction with combination therapy in the comprehensive management of diabetes-related CKD? Role
So
of
there is
lifestyle.
enough, yes. So there's enough data to tell us that how low protein diets have benefited kidney disease, and this is from ages now. People have to restrict their protein intake, and now in fact we talk about using keto analogs in association with very low protein diets, so that we don't even risk the patient for sarcopenia. So obviously, very low protein diet coupled with keto analogs, that is a nutritional aspect. Having some good physical activity so that the insulin resistance can be reduced in such cases. Smoking cessation, because that will worsen the endothelial dysfunction that's already bad in such cases. So all these things need to be taken care of, and lipid management also, because we have seen that patients with poor lipid function will have a high risk of adverse cardiac event in cases of kidney disease. So it is these four aspects of four pillars: nutritional management, that is protein restriction, along with the usage of keto analogs, usage or smoking cessation, complete cessation, lipid management, and moderate degree physical activity should be ensured in such cases.
Thank you. Now, the last question.
Yes.
You know, patients often have to shuttle between different professionals, endocrinologists, nephrologists, cardiologists. So, how can healthcare professionals collaborate to provide comprehensive care for patients with diabetes and CKD?
So very, very good question, sir. And I feel the key should be early screening and early diagnosis. When you do early screening, early diagnosis, there is no need of referral to a higher center, no need of referral to a nephrologist. Already we have very less nephrologists, and they have to focus more on kidney transplants and advanced kidney disease, end stage kidney disease. So that is why the role of the primary care physician, the consultant physician, the endocrinologist or diabetologist is very key in early screening. When you pick up the patient, early screening, institute drugs like SGLT2 inhibitors, RAS inhibition, and focus on lipid management, you can drastically reduce the rate at which eGFR declines in the patient. And for many years together, with comprehensive blood pressure and diabetes management, the patient can be saved from entering the late stages of kidney disease. That is a beauty, that today we have treatments which are available. We have good prognosis of those treatments. The only thing is that we are not screening enough. And that is why the take home message today from my end and from your end also will be to all physicians to start screening more and more in practice, and keep CKD at the back of your mind when you're looking at diabetic patients, so that if you initiate at an early stage, the requirement of referral to higher centers or to nephrologists would reduce, thereby reducing the trouble caused to the patient also.
Thank you very much for that insightful presentation on diabetes and CKD.
Thank you.
I'm sure the listeners would benefit from this and spread this message that early diagnosis is the key, early detection is the key. Don't wait for the symptoms. With
Absolutely.
that, I hand over the platform back to the organizers. Thank you very much.